Hello and welcome to Radcliffe Cardiology's webinar in association with Interventional Cardiology Review and supported by GE Healthcare. I'm Harriet Seeger and I'm delighted to be joined today by Dr. Benamer, Interventional Cardiologist from the Institut Cardiovasculaire Paris-Sud, who is going to be talking to us about the role of imaging to guide procedures in complex lesions. As more complex procedures are attempted in interventional cardiology cath labs, the need to boost image enhancement becomes more and more important. And today, Dr. Benamer will talk us through some cases that address typical issues in stenting complex lesions and help us to understand a new set of advanced imaging technologies that can be used in routine and in complex lesions. Dr. Benamer, welcome.
Hello. Hello, everybody.
Fantastic to have you with us today. And just before we start, just a quick note to our audience. You'll have the opportunity to ask questions via the text box on your screen throughout the course of the webinar, and Dr. Benamer will answer as many as possible at the end. Okay, so I'm going to stop talking now and hand over to Dr. Benamer.
Okay, so I'm going to show you with some cases how PCI Assist helped me in my daily practice for complex lesion PCIs. So what are some kind of complex procedures? First of all, the bifurcation cases, which is very important to assess the fact that the stents are well deployed, especially on the proximal part of the bifurcation lesion, with the POT technique, which is a very important step of the strategy, the proximal optimization technique. So to make a good POT, it is very important to assess the position of the balloon and to be sure that we are covering the carina. Then it will be more useful, more easier to take the distal strut and to open the distal strut and to put the second stent in case of two-stent strategy. The second kind of complex lesions are long lesions with the use of more than one DES to optimize the overlap of the stents and to be sure that we are not making geographical miss between both stents. And the BVS is also challenging. BVS are radiotransparent scaffolding. So to put these kind of devices in the coronary arteries, it is complex, especially when we use more than one BVS. So how it works? With the stent vessel V's, we enhance the visibility of the stent. A very short acquisition can make a very good image of the stent. So it is very useful in our daily practice. And then we put the overlap of the coronary angiogram that can clearly show you the stent and the position of the stent inside your coronary artery and the relation between your stent and the side branches or ostial lesions. Let me show you the first case, which is a complex case with a left main disease. In this 72-year-old male, we have in his cardiac history previous PCI of the LAD circumflex and the right coronary artery with DES use. On this view, you can clearly see that the left main is diseased at the distal part with a bifurcation lesion, and we have also a lesion of the ostium of the LAD and a tight and long stenosis of the proximal circumflex. I mean by long stenosis, more than 5 millimeters. That's for the strategy, it's very important because when we have more than 5 millimeters, usually we use a T or tap stenting with the two stents in bifurcation. So the challenges for this bifurcation lesion will be, first of all, because it is the left main, to well cover the ostium of the left main and to have a well position of the balloon to make a good POT to cover the carina and to optimize the opening of the stent on the proximal part of the bifurcation, and also to take the good strut to do the kissing balloon, and then to optimize the positioning of the second stent in the side branch to do T or tap stenting. Here you can clearly see with this stent vessel V's that we can see very precise positioning of the stent in the left main and the relation between your stent and the ostium of the left main. Here we have the balloon for the proximal optimization technique. This proximal optimization technique must be done with a well coverage of the carina to optimize the opening of the strut just near the side branch. The pot technique is a very important technique for bifurcation lesions. First of all, the side of the stent, the choice of the side of the stent is done with the distal parts of the bifurcation. Then you can clearly see that we will have a gap between the vessel and the stent on the proximal part of the bifurcation, which is with the diameter which is more important. And to be sure that we will be able to get the distal strut without going between the stent and the wall of the vessel, it is important to impact well the proximal part of the stent, get the distal strut to open it with a balloon, and then put the second stent through the distal strut to cover the side branch. So for this case, we can clearly see that with the stent V's, the stent was not well open on the ostium. So it is very important to open it well with the non-compliant balloon and to make a very proximal optimization technique. And here with the stent vessel V's, we can clearly see the position of the balloon and the carina. Here the pot done with a non-compliant balloon, and here we can assess that the stent is well open on the proximal part of the bifurcation. After this step, you can clearly see that we have a plaque shifting on the circumflex. So the next step of this bifurcation PCI is to rewire the circumflex, open the strut with a balloon, and then to put inside the vessel, the circumflex, the second stent to make a T or a tap. It depends on the angulation of the side branch. Here we can clearly check the good position of the stent with the stent vessel V's. It is very useful, very quickly done, and here you can assess clearly the positioning of the second stent, minimizing the overlap inside the left main, and to be sure that we will not have a geographic miss of the ostium of the circumflex. Here we have the result of the stent V's. We can do a repot at the end of the procedure to be sure that the stent is well impacted at the end of the procedure, and then we can assess the result of the overall bifurcation. Here we have all the steps of this procedure. First of all, checking the fact that the balloon is well positioned for the pot technique and the relation between the balloon and the carina. Here we assess the fact that the stent was well open on the proximal part. Here the stent was not open. After the pot, it was well open here, and to check the position of the second stent on the bifurcation to optimize this position, and then to assess the final result on this complex lesion of the left main. Here you can check the result, which was good, with a good position of the second stent on the side branch, and the stent well open and covering the ostium on the left main. So the challenges were the position of the second stent in case of two-stent technique for bifurcation lesion, the optimization of the pot technique to be sure that the stent is well open, the choice of the distal strut of the bifurcation to optimize the coverage of the ostium with the stent of the main vessel, and it was really useful. PCI assist was really useful for all these steps and all these challenges. And with this tool, it was more comfortable to do this kind of complex cases. And we can also get another case explaining these facts of the usefulness of this tool for bifurcation cases. Here, another case with a LAD bifurcation lesion. We planned also to put two stents because both vessels were diseased in this old man. So the steps are to put the stent on the main vessel, to do a proximal optimization of the proximal part of this vessel, and then to use a second stent in case of a bad result on the diagonal branch. This bifurcation is 111, Medina. So we put here, after predilatation, the stent on the main branch, which was the LAD. And here you can clearly see with the stent vis that the stent was not well open on the proximal part, so the pot was very important, especially in this case. And with the stent vessel vis, you can clearly check the proximal part of the stent to be assured that with your balloon you will not do a geographic miss with the pot technique. Here, after the pot, the stent is well open, and with the stent vessel vis, we can check the relation between the stent and the side branch. Here we did the kissing balloon. As you can see, with the kissing balloon, the result on the side branch was not good. That's why we plan to do T-stenting in this case, because the result of the ostium was not good. So here with the stent vis, it is clear that the stent is well open at this part. Maybe here not completely open. So to check the ostium here, the stent vessel vis is very useful. So we rewired the side branch, and we positioned the second stent on the side branch with very precise positioning with the stent vis here and stent vessel vis to be sure that the ostium will be covered without any overlap inside the main vessel, because we have here shoulder of the opened strut on the ostium of the side branch. So it is not necessary to do a tap in this case. So we deployed the stent, we did the kissing balloon, and then we assess the opening of the side branch. As you can see here with the stent vessel vis, we can clearly check the position of both stents and the opening of both stents in this bifurcation. Here we can see the bifurcation in two views with the stent vessel vis, with a good opening of the stents and a good position of both stents. So, like for the left main case, this tool was very useful to optimize the T or TAP stenting in complex bifurcation lesions, and it was very useful also to assess the fact that the stents are well open and covering all the area of the disease area of the vessel. Another case which is challenging is BVS use. Here we have a case of a very young male with a two-vessel disease with a long stenosis of the LAD and a very long stenosis of the circumflex. So we plan to put BVS in this very young patient. So here you can clearly see the markers of the BVS of the LAD, the proximal marker and the distal marker. Here we have the marker of the balloon to do the optimization of the opening of the BVS. So it is very important to be sure that we are not making a geographic miss with the balloon, non-compliant balloon. So here we can check clearly with the stent vis that the balloon is inside the BVS. Here we can clearly see that the balloon is outside the BVS, too distal. Here also too distal, and here we have the good position for the optimization of the opening of the BVS with the non-compliant balloon, and we are sure that we are not making any geographical miss with this balloon. That's a very important step. Another thing with this, which is very complex with BVS use, is when you have to put two BVS for very long lesions. In this case, it was the circumflex. So the first BVS was positioned on the distal part of the circ, and the second one, you can here clearly see that the second BVS is too distal. Here we have the marker of the first BVS, the proximal marker of the first BVS. So with stent vis, it is very quick, very useful to use it in daily practice to optimize the positioning of the second BVS. Here we are a little bit too proximal. The optimal positioning is when you have the marker of the distal BVS here, the marker of the proximal BVS here, and at the middle, the marker of the balloon. Here another case, and in this other case, we have a small overlap, less than 1 millimeter, maybe less than 0.5 millimeter of overlapping between two BVS. Here, the result in this case of a young man using 3 BVS for two-vessel disease. So it is clear that this PCI assist is useful, as very helpful for the use of BVS, which are very radio-transparent. So in our daily practice, we need some tools to optimize the visualization of this kind of devices, to optimize the PCIs for very young patients. So my conclusions will be that this tool is very helpful in daily practice for complex bifurcation PCIs, especially when the vessels are also calcified and fibrotic, because it is very important also to check the fact that the stents are well deployed in the vessel. It is also very useful when we use devices for long lesions, for DES, use of multi-DES, to optimize the overlap, to optimize the coverage of the lesion, to be sure that we don't have any geographical miss, And of course, it is very useful when we use BVS with these very radiotransparency devices. So in our daily practice, it is more comfortable for us to have this kind of tool to do complex cases. Thank you to the audience for your attention.
Thank you so much, Dr. Benamer, for a fascinating presentation. That was excellent. We've had quite a few questions in from the audience, so I'm going to start with the first one. Do you need a specific acquisition protocol for stent viz or stent vessel viz?
First of all, thank you very much for your interest for this presentation. For the acquisition, it's very simple to do. Very simple and very quick. You only have to center the screen on the balloon markers, and then perform with a good collimation 30 images. It depends so the rate of your acquisition, and then you can simply do this stent viz. Very simple, and you have to wait the results. Then it will be very clear to you that the stent is open or not. And if you have to do a stent vessel viz, you can add to this stent viz an injection like you do it very usually. So a small injection in the coronary artery, then you will have the stent viz at the beginning of your acquisition, and the second part will be the ossification of the vessel.
Next question. Would you recommend using stent viz and stent vessel viz also for complex procedures?
Yes, as I said before, it is very interesting, very useful and helpful in case of bifurcation lesions. And in left main also, as we saw on the previous cases, to be sure that we are not doing geographic miss of the ostium, or if you want to avoid the bifurcation at the distal part of your stenting area. So it is very useful in these cases. And of course, the main thing in my practice is to be sure that the stent is well open, that we know that if the stent is not well open on the PCI, you will have a higher rate of restenosis process and a higher rate of acute thrombosis of our stent. So in my practice, I use it very often.
Fantastic. Is there a specific clinical challenge where PCI assist was more useful than others?
Yes, the principal challenge is the left main, because if the job is not well done, the maces will be very bad maces. And the second point is technical difficulty with the BVS, because we cannot clearly see BVS. So with this tool, it is more helpful to do, especially when you have to do long lesions with two BVS. And edge-to-edge technique is difficult without this kind of tools. With the PCI assist, especially with the stent vessel viz and stent viz, it is more useful.
Okay, we have a few more questions. I hope you can hang in for them as well. Do you think that PCI assist can help reduce the number of stents used in a procedure?
Absolutely, absolutely, because sometimes you have to be very you have to be very precise on the positioning of the stent. If you are not very precise, you have to put another stent on the proximal or the distal part of the previous one. So if you do stent vessel viz, it is very clear that you have the position of your stent inside the vessel, so you don't make any geographic miss, and you will not make any missing areas of stenting. So in my practice, I use this kind of tool to reduce the rate of another stent used on the proximal or distal part. And on the other point is when you have to put two stents, because the length of the lesion is very, very long, you can reduce the overlap area between both stents, and of course you will avoid also a geographic miss between the two stents. So it is important to use.
Okay, thank you. Well, it's been fantastic. You've answered so many questions, Dr. Benamer. We thank you for that, and it's been a pleasure having you with us. So thank you for joining us.
Thank you very much. Thank you for your attention. It was really great to share my experience with you with this PCI assist, and maybe I will see you at PCI next week.
Oh, we hope so. Fantastic. Well, so that was Dr. Benamer speaking to us from Paris in France. And you can find out more about Dr. Benamer in the link under this video. And you can also hear, as Dr. Benamer just said, he's going to be presenting at EuroPCR, which starts next week on the 17th of May in Paris. G will be presenting in the training village as well, hosting a hands-on clinical sessions led by key opinion leaders such as Dr. Benamer, who will be presenting some more cases. And other doctors as well, Dr. Thierry Lefebvre, Dr. Thomas Tovas, Dr. Philippe Garot, and Dr. Patrice Guérin, who will all be sharing their experiences of CTO, TAVI, LAAC, and mitra clip procedures. So it just remains for me to say thank you, our audience, for joining us today. And I'd be really grateful if you could rate this webinar using the star rating system that you can see on your screens. And to listen to any of our other webinars, please turn to the Academy section of our website, which is at radcliffecardiology.com/academy/webinars. So that's all from me, and wishing you all an excellent rest of the day. Thank you and goodbye from Radcliffe Cardiology.
Thank you.